My name's Matt Levine. I'm faculty from Northwestern Memorial Hospital. For about the last 15 years, I've been in charge of our residents' orthopedic curriculum, and I've come across a lot of little tidbits and nuggets along the way, so I wanted to share a lot of them with you guys and all the interesting cases in a talk I call Injuries That Are Worse Than the Initial X-Ray. So what we're going to do is review actual cases that I've come across, and we're basically going to talk about injuries that are much worse than the X-ray might lead on. And we'll talk about tips that you can apply to your practice to change the way you practice so that you won't make these mistakes. And we're going to start with kind of some basic bread and butter ones, probably you all know them, and then we're going to get, as we go along, a little more difficult and more rare, so there should be something for everyone. So let's get right into it. We're ER docs, we love cases. This is a case I had actually from my first or second year out of residency, and this was a patient who she's on prednisone chronically, goes to sit down on a couch. The cushion had no cushion in it, and she sat on the spring, and so her butt really hurt. She saw her PMD. Her PMD actually sent her for physical therapy. She comes into the ER with this left hip pain. It's 10 days later. We do x-rays. The x-rays of her left hip are negative. These are the representative images. 2 days later, she comes back, can't walk. So subtrochanteric fracture, hopefully it projects for you guys, on the left side. So classic occult hip fracture, right? So an occult hip fracture is defined as a fracture that's present, but you don't see it on the x-ray. There's nothing to see. The x-ray is negative, but there's a fracture. So most of the time, we'll see these in the elderly, and we have to be really cautious about this because we see tons of these. And the elderly are tricky because they might not be saying, hey, I have hip pain. It might be butt pain. It might be back pain. It might be knee pain because we know that hip pain refers classically to the knee. But 2 to 9% of hip fractures are occult. So if we just x-ray negative send all these people home, we're going to miss some. We're all going to miss some then. Also be wary of young athletic people who come in with hip pain that you can't figure out so you don't miss the dreaded femoral neck stress fracture, because those will also often elude your plain films, and if they continue to bear weight on those, they'll end up with complete fracture. So I took that microscopic table there from the American College of Radiology appropriateness criteria. Thought this screen might be bigger. And so as far as what to do imaging-wise if our x-rays are negative. So the American College of Radiology says in their appropriateness criteria that MRI gets the highest rating. It gives it a 9, as in most usually appropriate. That's its highest rating. And so from their review of their studies, 100% sensitive MRI. Now, in my hospital, if you order an MRI, from the time you order the MRI to getting the results, 5 hours. So not always practical for us. So what about CT scan? CT scan has some advantages, meaning that it's available, it's rapid, we get a read back quicker, and patients tolerate it better. You know, they can actually, it's quick and they can sit still and manage. It doesn't take an hour to get it. So what did the ACR appropriateness criteria? They gave it a 6. And a 6 is maybe appropriate. And the main data they used for that was a study that they took. It was a retrospective study of 190-something patients that had x-ray negative. And these are middle-aged to elderly patients with hip pain and a negative x-ray. Of 190-something patients who all ended up getting CTs, of the 88 of those that did not have a fracture on the CT, 4 of them did have a fracture on their MR. So they ended up with a 95% sensitivity out of that, and they gave it a rating of a 6 out of 9, may be appropriate. So how do I apply that to my practice? The way I apply that to my practice, and people might apply it differently to theirs, is that if I have a patient who my suspicion is really low to begin with, but not quite low enough to stop, if they're pretty much walking and are going to go home if a study's negative, then I do a CT. Because if I figure, the chance that they have this is single-digit %, so I have a low pretest probability, and now I'm adding a test that's negative, meaning a CT that's 95% sensitive, my post-test probability is getting really, really, really low. But if I have a patient who can't walk, okay, and I know they're not going home, then I just admit them and they can get them the MRI. They can get the MRI during their stay. Might as well admit, because they're getting admitted either way, get the test that's 100% sensitive. And that's how I apply it to my practice. I know that some people will only do the MR, so it all depends on if you're zero risk averse or will tolerate a very, 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 very small amount in the right clinical setting. All right, and there's another case that we came across, occult right femoral neck fracture, nothing on the x-ray, but a little non-displaced fracture as indicated by the radiologist arrows on the CT. So in general, these occult hip fractures fall under the category of fractures that are not ruled out by a negative x-ray. So we all know about, and you have to be aware that there's going to be some injuries that a negative x-ray does not rule out the fracture. We all know about the scaphoid fracture and how it's drilled into our head to check for snuff box tenderness. Coccyx fractures, are notoriously difficult to interpret these films. There's all sorts of suture lines on it. So, don't tell a patient your x-ray is negative, so you don't have a coccyx fracture. And the reality is you can make the diagnosis clinically without even using x-rays. Stress fractures are classically have negative x-rays for 4 to 6 weeks. And non-displaced growth plate fractures that are Salter-Harris 1 and 5 can be negative. You might not see widening or narrowing of the growth plate. So keep those in mind that those are some scenarios that you still might have negative x-rays despite there being a fracture. And that's certainly not an all-inclusive list. All right, another case. So this patient was in a motor vehicle collision and their thumb got bent back against the steering wheel. We get an x-ray and there's that little, just not that dramatic looking fracture on the ulnar side of the proximal thumb phalanx. So what injury does this patient have then? What is this going to end up being? So this is going to be right. So this is a gamekeeper's thumb, okay? What inserts right there? The ulnar collateral ligament inserts right there. So that's a gamekeeper's thumb. Whether you go through the rigmarole of the stress test or find instability or not, that is right where that ligament inserts. So so if you see that, that has to be a thumb spica and a referral for ulnar collateral ligament injury. Oops. There you go. So classically, only about 20% of the ulnar collateral ligament injuries will have that little bony fleck. So it's easy if you see the fleck. If not, it's a clinical diagnosis by stress testing, as pictured here by Frank Netter. Now, the stress test, if you've diagnosed a bunch of these, the stress test hurts. It's really painful. It limits some patients can't tolerate it at all. Textbooks will say, well, then numb them up. Do it under anesthesia. To be honest, I find that really impractical. If somebody has bent their thumb back and their thumb's tender and swollen, and this is where they're tender, right there, then that's a gamekeeper's thumb as far as I'm concerned. There's no way I'm not sending that patient home with a thumb spica splint and follow up within a week with the hand surgeon. It doesn't matter if I feel the stress test instability or not. That's how I'm treating them. So I advise you guys, if someone's tender right there after bending their thumb back, just thumb spica them and send them to hand in a week. All right, this patient stepped awkwardly off the curb, has a lot of mid-foot swelling and tenderness, and has a little avulsion type fracture at the base of the second metatarsal right there. So the fracture itself looks pretty benign, but the injury's not. What's the injury? Right, so this is the classic Lisfranc. Now, Lisfranc's easy if your first and second metatarsals are splayed apart, right? But often it's much more subtle than that. And like Dr. Hogreff just mentioned before, we often miss Lisfranc injuries. So there's some other ways that you need to be able to diagnose this injury for the subtle cases. So one is that the medial border of this second cuneiform should line up nicely with the medial border of the second metatarsal. Those should line up nicely. There should not be any widening between the first and second metatarsals or the first and second cuneiforms. Okay, so if any of those are present, that's a Lisfranc injury. But sometimes even that is not particularly obvious. Sometimes all you get is a little flex sign, which I hope projected, which all you get is a little fleck of bone in that area. That fleck of bone signifies an avulsion fracture of Lisfranc's ligament. Lisfranc's ligament goes from right here, the distal lateral aspect of that first cuneiform, to right here, the medial base of the second metatarsal, from there to there. So if you get a little fleck of bone in between there, then that means that there has been an avulsion fracture of Lisfranc's ligament. And remember, Lisfranc's ligament, that's the main stabilizer, this whole midfoot joint. You take that out, and you have a totally unstable midfoot that almost always ends up being an operative injury. Now, let's say you still don't determine any of these on your films. The other additional things you can do are, like what Dr. Hogarth mentioned in his talk, a weight-bearing view. Now, a weight-bearing view is not as practical in my house because you have to send them up to the 4th floor radiology suite where they have the right technology from the stand on a plate and for them to be able to have the beam kind of angle while they're standing on a plate. So I haven't been able to do that actually in my ED. You can consider doing comparison views of the unaffected foot to look for widening, or you can just go right to CT, which actually ends up being the easiest and more sensitive thing in a lot of the scenarios for it. All right, next one. So this patient jammed her finger playing volleyball, and we find that there's a fracture right at on the distal phalanx at the base of it on the dorsal aspect. So there's a structure that inserts right there. So this fracture, again, thinking anatomy, if you have that fracture right there on that phalanx, what's the injury going to be? Right, I heard it. That's going to be a mallet finger. Okay, again, thinking, because how could you not have a mallet finger if you get a fracture right where the extensor digitorum inserts? So classically, it's a clinical diagnosis, but they don't always come in with their finger looking like that. If they do, it's easy, but sometimes they don't. So the fracture will be present a good 20-30% of the time, but if there's no fracture, then you rely on your clinical exam. You have to make the patient fully extend their finger. Sometimes patients cheat. They'll actually take their other finger and passively extend it. So they can passively extend their finger. That doesn't count. They have to actively do it. So what happens is you're doing some activity, your body wants to keep your fingers straight, and then something comes along, causes forced flexion. So in Chicago, that's usually like a 16-inch softball. I've never heard of anywhere else playing that except Chicago. But it crushes your fingers. And so patients come in, they can't extend that finger. Now, if they have the fracture, that's great. It makes it so much easier. Now, the treatment for this is you put a little hyperextension splint on. Now, look at where the fracture fragment is now, and look at where it is after the hyperextension splint is placed. It brings it back in contact with the rest of the phalanx. That position has to be maintained for 6 to 8 weeks if it's a bony injury, and even longer, like 10 to 12, if it's purely a tendinous injury. So for that reason, we don't splint the entire finger. We want them to comply with the splint. The patients sometimes have trouble processing that it's just a little finger injury. I don't want to wear this splint 24/7, for 6 to 8 to 12 weeks. But they do. They have to wear it. The clock starts over with the healing if they take it off, and the hand surgeons will restart the clock with them. So in general, if you have a patient who their finger doesn't look right, has a deformity, it doesn't flex or extend right, but the x-ray is negative, just splint the finger in its anatomic position and refer it to see hand in a week. Nothing bad will happen to your patient that way. But if it goes 2-3 weeks or longer without diagnosis, then things start to stenose down by then, and the patients will be left with a deformity. All right, let's see if we get a little less common now. So let's go into the less common stuff for those of you who this is just boring them. So this patient had a fall on their hand, is complaining of pain over their thenar eminence. So we do the x-ray, and we see this little bony avulsion on the ulnar aspect of the first metacarpal. Does anyone know the name of this fracture? Right, this is the classic Bennett fracture. So that's one that we all had to know for our boards, right? But we don't see it that much. And it's not just the simple fracture, but there's even, and on this view you can see, there's even sublux of the first metacarpal. So these are actually unstable fractures. What happens is the volar oblique ligament remains inserted on the fracture fragment, and that stays in its normal anatomic location, while the rest of the metacarpal sublux is radially and dorsally. This is an unstable carpal metacarpal joint. The treatment of this is actually reduction in thumb, it needs to be reduced, reduction in thumb spica splinting, and rapid follow-up. And the reason the follow-up has to be rapid is because most of the time reduction will not be maintained. And it has nothing to do with your technique. It has to do with the pull of the abductor pollicis longus tendon. The APL will tend to pull this out of reduction, and a lot of these patients will end up having to get ORIF for this. So they need reduction, splinting, rapid follow-up for an unstable carpal metacarpal joint. And you know that that has significant morbidity associated with it 'cause it's your thumb. So. All right. So we get big football player, big burly guy, twisting knee injury, playing football, comes in, his knee's big, he's swollen. You're wrestling him to try to get a knee exam in. He's having none of it, okay? He's winning. He's winning the battle. You can't detect any laxity. What am I going to do? You get an x-ray at least, and the x-ray shows this little, let's see if we got it here. Did I put an arrow? Yeah. This little avulsion fracture, okay, that's on the lateral aspect of the proximal tibia, just distal to the plateau. Anyone know the name of this one? Nice. Ooh, smart crowd. Okay, so this is the Sagand fracture. So the Sagand fracture was actually found by, of course, a guy named Sagand, Paul Sagand, in the 1800s. Before they even really had x-rays, he found it on cadavers, and he found that people with cadavers with knee injuries who had this avulsion also had ACL and medial meniscal injuries. And then in the 1900s, more in the 50s, 60s, multiple studies actually confirmed that there's near 100% correlation with ACL tears with this, and a fairly high correlation with meniscal tears with it too. So while the fracture itself looks like a benign little avulsion, there's significant meniscus and tendon injury associated with it. So if you see that, you know that. There's even a sort of relative of this called the reverse Sagand fracture, which would be if there's the same sort of little avulsion fracture on the other side. That would be the reverse Sagand fracture, and that's been shown to be associated with medial collateral ligament tears, medial meniscus tears, and PCL tears. So really, the take-home of this is that any sort of tiny little avulsion fracture that you see on either side of the proximal tibia is probably a sign of substantial meniscus or ligament injury. So keep that in mind. This was a case we had where it was a tibial plateau fracture from a motor vehicle collision that also had a Sagand lesion with it. So if you remember, one of the operative indications for tibial plateau fracture is if the ACL is torn with it. So we pretty much are sure now that this patient with this tibial plateau fracture is going to have an operative fracture because they probably took their ACL out with it. All right, and last case, this is another one from one of my first couple years out, and it haunts me to this day. So this is an 18-month-old brought in by mom, fell down 3 or 4 stairs the day before, and he's been limping since. And you examine him, his distal thigh's kind of puffy. He's limping around, he's playful, but he's puffy, he's definitely tender there. You do an x-ray, you find that there might be a little kind of irregularity on the AP view, and if you blow up the lateral view, he has this little fracture that's read by the radiologist as a Salter II fracture of his distal femur. So we put this patient in a long leg splint and referred him for ortho follow-up. But what haunts me about this was 10 years later, I was going through my files of cases I saved, making some educational material, and it all of a sudden hit me that this was a metaphyseal corner fracture. Because at that point, by then, I knew what one was. And so the reason that's horrible is the metaphyseal corner fracture is associated with non-accidental trauma. It's one of the most specific fractures associated with non-accidental trauma. So, and it is indeed a Salter II fracture. Now, that tends to occur in the tibia, the distal femur, as in this case classically, and the proximal humerus. And it really happens in this age group, 18 months to 2 years old. And it's an injury that's from torsion and shaking. And the reason it happens in this age group is because those kids are small enough to be shaken and also small enough to not be able to really defend themselves. And so the extremities kind of flail around and they get repetitive microtrauma and ultimately get these corner fractures. Sometimes these fractures will extend all the way around the distal tibia, and that's where they become a bucket handle fracture. But in this case, in a case like this, it's just a corner fracture. This fracture was actually first discovered by a pediatrician who was caring for all these kids who had traumatic subdural hemorrhages from abuse, and said, gosh, all these kids have these funny corner fractures, and that's where that actually first became discovered, that this was an injury of abuse. So be wary of all the fractures that are associated with abuse, the ones that we've kind of been told to study. Multiple fractures at different stages of healing, rib fractures, humerus fractures, skull fractures, any fractures of the femur. I mean, femur and humerus. The kids of this age should not be able to generate enough force to break a humerus typically. Now, these injuries, the corner fractures, actually can be bilateral, and they can be very subtle, as this film is. You kind of have to blow it up to get a pretty good image of it. So if you're going to document these at multiple sites, you can't just get a babygram, okay? The babygram, the one shot of the whole baby, you're going to miss it because of how you need dedicated films of the long bones. So that's why you have to actually do the skeletal survey, and you can't just settle for the babygram. All right. So with those in mind, my take-home points, remember that there's certain fractures that are not ruled out by negative x-ray. Hip fractures are the ones you're going to come across the most, but of course scaphoid fractures, coccyx, Streck's fractures, and the Salter and the non-displaced Salter 1 and 5 fractures. And then be aware that there's certain fractures that might look minor on your plain films, but they're not minor fractures, like the ulnar collateral ligament injury, so any fracture on the ulnar aspect at the base of the thumb, any fracture at the base of the first metacarpal, the mallet fracture at the base of the dorsum of the distal phalanx, anything at the base of the second metatarsal, any avulsion fracture of the proximal tibia, whether it's medial or lateral, and of course, the fractures of abuse. Any questions? All right, and as far as my references go, I'd be glad to give anybody any references, but there's one reference I'd like to talk about, my favorite reference, and it's our ortho teaching file where I took most of this material from. This is something that is free, open access. We made this 10 years ago, and basically it's designed for people like you and me. It's for busy clinicians who need a quick answer in the middle of a shift. Any of my residents know that if you want to get me mad, if you have an ortho question during your shift, go look on Wheelus. That gets me mad, because that's for orthopedic surgeons. This is for ER docs. So if you go to our orthopedic teaching file, and all you have to do is Google ortho teaching or anything like it, it'll be the first hit. If you click on our search by diagnosis tab, you'll just get a listing by body section of all of our diagnoses. We have 109 and counting. Pretty much most anything you guys will come across in practice, we've made a file for. And if you click on one and enter a case, each case enters just like the cases we had today. I took these cases from our file with a one-liner and an x-ray. And you can navigate through each case on the left-hand margin, get just a paragraph background, a paragraph on what the history and physical exam would be like, a paragraph on what the x-ray findings would be expected to be, and then a paragraph or two on what's the ED management for that. So we also have a separate section of it that has videos and slides and some particularly useful videos on there. We have techniques to do arthrocentesis of a bunch of different joints, us doing it actually where we injected a cadaver with methylene blue and tapped all their joints, and a cool video, link to a video on checking compartment pressures. So that's my shameless plug for our file. I hope you guys explore it sometime, and that's it. Thanks for being awake and being attentive and for listening to my talk. Any questions?